Sedation and analgesia in the ICU using one piece of paper. Not us learning everything in one graph. Every patient who is intubated should be on one analgesic agent and one sedative agents. That's first and foremost, babies. Analgesia, which is in green, and then our sedation is in yellow. So obviously this is all mu agonist opioids, right? Fentanyl, morphine, hydromorphine, with the exception of ketamine, which is an NMDA antagonist. Obviously, these three are opioids, right? So they're going to have opioid-like side effects like respiratory depression. One thing to note is that fentanyl can have wooden chest syndrome. Morphine, a lot of people sometimes will get itching with this. They can cause hypotension because of histamine release. And then the one thing I will say about ketamine is that it can cause hypertension, tachycardia, and K-hole. It's not good if you've ever seen it. Morphine, hydromorphine take a little bit longer for onset, but fentanyl is pretty fast as well as ketamine is pretty fast. To be a superstar, I also wrote out for you which ones are safe to use in kidney disease, like fentanyl, for example, which ones are metabolized by the liver, etc. The other thing I will say is that there was this talk about ketamine causing increased ICP, which was debunked. And note that at lower dose, ketamine will be analgesic, but as you go higher and higher and higher in the doses, patients will become dissociated, and that's when you get this K-hole. Okay, now moving on to our sedation. So propofol, this is a GABA agonist. The things that I want you to know for side effects for this is infusion syndrome, okay? Propofol infusion syndrome, piss. And it's gonna piss me off if this happens because this is bad. They get rhabdolactic acidosis, AKI, hyperkalemia. This ain't good, baby. Moving on to our girl, Precedex. This is a central alpha-2 agonist. Does that sound familiar? Yeah, it's clonidine in IV form. Now, I love my girl Precedex because it has something called cooperative sedation. It gives you a lower RAS. And so a lot of times we can extubate our patients on this because it does not decrease respiratory drive as well. Moving on to the benzos, which is midazolam and lorazepam. The high yield for lorazepam is that it can cause propanol glycol toxicity, which presents as lactic acidosis and an osmolar gap. Okay, and then both of these, because they're benzos, they're going to be very high risk for delirium, which is why we don't like them. And also their off time, look at this. You're trying to wean your patient off to extubate them. You're talking about a long time before these patients can wake up. And that's because it's very lipid soluble, so it's going to build up in their system. Now, what do we use for our sedation goals? We use the RAS system. Our goal is always -1 to 2. The last thing I will say that is propofol and Precedex are better than benzos, period.